So ovulation occurs 10 to 16 hours following that luteinizing hormone surge. When this happens, obviously all the rest are occurring, and we also get an increase in progesterone. The increase in progesterone is going to inhibit the hypothalamus and the pituitary hormone secretion. At this time, we're also going to get decreased estradiol libido. Once again, this is going to be happening around age 10 to 14. And then finally, our luteal phase. It's going to last about 14 days. The egg at this time is going to pass into the fallopian tubes. Now, our egg is only viable for 1 day, but important thing to note for contraception, sperm is viable for 3 days. So if there is sperm in the fallopian tubes 3 days before that egg comes down, it's possible that it could still be fertilized. So just something to keep in mind, right? We're going to still have those remaining follicular cells that do not become the dominant follicle. Those are going to become our corpus luteum. They're going to secrete those androgens, estrogens, and progesterone synthesis. And the functions will decline after 10 to 12 weeks. We'll see a decrease in progesterone, and then we'll go back into menses and start the cycle of hormone therapy. Okay? Does anyone have any questions about any of that? Very brief overview. Okay. All right. So now the fun part is the role of hormones in contraception. So estrogen specifically is going to suppress FSH release. So if we remember back from our little picture there in the graph, estrogen drops. That's when we get our FSH and LH shoot up, which is going to cause ovulation. So estrogen is going to help block the LH surge. Okay. It's also going to stabilize endometrial lining, and it's going to provide cycle control for some of our patients that would prefer to have more regular cycles. Progesterone, I like to say that's really the star of our show here because it's going to fully block that LH surge. Okay, it's going to fully inhibit ovulation, and it also inhibits implantation because it suppresses our endometrium. It also will cause some cervical mucus thickening, which will help to decrease sperm entrance up into those tubes. So it'll prevent the sperm. Okay. There's different types. So we have 2 types of estrogen that we'll see in our compounds. We have ethinyl estradiol and mestranol, and then we'll have various types of progesterone. The most androgenic of our progesterone, which is something that you should take note of because it's important for the adverse effect profile, is the second generation. So the second generations have more androgenic properties versus our third and fourth generation. So our third generation is actually the least androgenic, which will make more sense when we get to adverse effect profiles. And then our fourth generation also is not very androgenic as well. And that's mainly because it's actually a spironolactone antibody, so it's a little different than the other progesterones listed here. Perfect. So obviously we use contraceptives for various things, not just contraception. You can see it in polycystic ovary syndrome or PCOS. You can see it in menorrhea, menorrhagia, endometriosis, premenstrual syndrome. Some patients that suffer with acne, contraceptives work really great for. Contraceptives have a lot of indications is the general point, right? So we don't just use them to keep pregnancy from happening, we use them for all of these as well. And it's also been shown to reduce the risk of ovarian cysts, ovarian and endometrial cancer, and also benign breast disease. It also has lowered incidence of ectopic pregnancies, anemia, and RA as well, or rheumatoid arthritis. So really, they do a lot of good things for moms, right? So this is basically just to show you there's various methods of contraception. Obviously, we're going to be focusing on pharmacologic ones today. Something to keep in mind for your patients. You know, obviously, these pharmacologic contraceptives provide pregnancy protection, but they don't prevent STDs. So it's important to talk to our patients about the use of, condoms. Things are going to provide a barrier. Because we have seen an uptick in cervical cancer with the rise of pharmacological contraceptives, and it's likely because we're not using that barrier. So just something to keep in mind and something to let our patients know. Obviously, our pharmacologic contraceptives are very effective, but they're effective at preventing pregnancy, not necessarily STDs. Okay. So our first knowledge check. Progesterone and estrogen both play a role in contraceptive therapy. Choose the statement that best identifies their roles in contraception and the menstrual cycle. I'll give you a few minutes. Okay, how many people think it's A? B? C? Okay. And then D? Everyone's being shy. Okay. So the correct answer is D. So progesterone directly blocks that LH surge, right? It effectively prevents ovulation. Estrogen assists in blocking the LH surge. So that's going to be mainly focused on our FSH, not our LH. So it's suppressing FSH, and it also is stabilizing the endometrium. So C, I know it's kind of tricky. So estrogen it suppresses FSH, but it doesn't effectively prevent ovulation. That's more progesterone's role. It actually is more of an assisting member of our contraceptive. And then progesterone obviously does get ovulation. Okay. All right. Our next knowledge check. Which of the following are potential benefits from the use of contraceptive therapy? There's more than one. I'll give you a minute. How many people think it's A? Okay. How many people think it's B? Okay. C? Okay. D? No fingers. E? Okay. And then F. Alright. So treatment of acne, right? That's something that we use contraceptives for a lot. C? Yeah, we reduce the risk of ovarian cysts. Now, the incidence of breast cancer, that can be a little tricky, right? So benign breast disease and breast cancer can be a little bit, they're different. Just something to keep in mind. Okay. And then F is our last one that is correct. So it decreases the incidence of any. So obviously not decreasing our risk of cardiovascular disease. And it's also not a treatment for eczema. In fact, sometimes some practitioners will avoid contraceptives with eczema patients because it can exacerbate that dry skin. Okay. All right, now we're gonna actually move on to our oral contraceptives. So our combined oral contraceptives, we have various different types. We have monophasic, biphasic, triphasic, which is our 28 days. And then we also have the extended cycle, which is 90 days. We're gonna go in a little bit in depth of what those are on the next slide. So don't worry about that right now. And then the other kind we have is progestin-only pills. A lot of times you'll hear them referred to as POPs or mini POPs. Mini POPs because the progestin element is actually very tiny, so it's mini. Just something to keep in mind moving forward. We'll go through each of these in depth more detail. Okay. So our monophasic, they have active pills that have the same amount of both estrogen and progesterone in each of them. So that's why it's monophasic. Okay. So some pros of these is that patients usually have less bloating and breast tenderness compared to the other formulations. And it's also easier to manipulate the menstrual cycle timing with these. All right, and then our cons is that we'll have a lot of breakthrough bleeding and spotting with these. So for patients who have bothersome, this might not be a good choice. Our biphasics have active pills that have the same amount of estrogen per pill. But the first half of the cycle, okay, there is okay. The first half of the cycle, the progestin and estrogen ratio is lower. And then the second half of the cycle, the progestin and estrogen is higher. Okay, so basically you're talking about the ratios. So obviously, like I said, the estrogen is the same amount. It's just that our ratio of progestin to estrogen changes throughout the cycle. So this actually makes it a little nicer for some of our patients because it mimics the cycle a little bit more. It's a little less convenient though for cycle manipulation. Our triphasic have active pills that have the same amount of estrogen per pill, but the estrogen gradually increases. This is acting more like a woman's natural cycle timing and her natural body rhythm. So for patients that want a very regular cycle, this is a really good pill for them, okay? And they're also gonna have more regular withdrawal bleeds. So the withdrawal bleed is what a lot of patients will say they're on their period when they're on a contraceptive. It's not actually necessary for a woman to have a period while they're on an oral contraceptive. So some of these will actually have placebo weeks. The placebo weeks are just that, they have no active in it at all. Sometimes they will have iron in it as a supplement. But if a patient were to skip those, they actually wouldn't be at risk for pregnancy. Because the placebo week actually has no hormones in it, essentially. If patients skip that placebo week, they don't get a withdrawal bleed. So sometimes that freaks people out because obviously as a woman, when you see that you have your period, you know you're not pregnant. So sometimes we keep that in there to keep people regular. It makes them feel a little bit better. But if your patients don't want a withdrawal bleed, sometimes you can skip that placebo week. Okay. And then also for our triphasic, something to note is if they take them out of order, the effectiveness is reduced because we are having that gradual progestin increase every 7 days. It's really important to controlling ovulation. If they do take that out of order, we can have an issue. So keep that in mind. All right. So some of the really big risks with combined oral contraceptives: hypertension, thromboembolism, some of our thromboembolic events like stroke and myocardial infarction. And then breast cancer is another risk, as we talked about a little bit earlier. One thing that I would like you to note is there are no studies, well, there are current studies that find little to no association with current or past use of breast cancer. So it's really a theoretical risk with the breast cancer component. And then with cervical cancer, once again, it's not linked directly to OCP use. It's thought to be secondary to the lack of gene. Okay, so obviously there are different side effects that we're going to be talking about a little more, but these are the really big ones that we should be watching out for. And when we're telling patients what to look out for these thromboembolic events, this is a really useful acronym to keep in mind. It's called AIDS. So the first thing is abdominal pain. They're going to have severe abdominal pain, likely. They can have chest pain, cough, or shortness of breath. Headache, which is very severe, dizziness, weakness, and numbness. For our E component, they can have eye problems such as vision loss of memory and speech problems. And then for our S component, severe calf effect. Once again, this is really related to our thromboembolic events, and something that all patients that are getting contraception should be covered. So some cautions and contraindications. It's contraindicated in patients that have thromboembolitis, thromboembolic phenomena, a history of cardiovascular and cerebrovascular disorders, which makes sense with what we were talking about before, that are thromboembolic events. Known or suspected breast tumor or estrogen-dependent neoplasm. So obviously, if we're getting hormones, that could feed that tumor potentially. And then adolescence, which is a complete concealed closure. Does anyone know why we wouldn't want to give that to a kid who didn't have an concealed closure? Anyone want to take guess?
Slow growth progression.
Exactly. So those hormones are actually going to cause the epiphyseal closure to grows. So it will sound different. All right. And then caution, it's not contraindicated, but please take notice. If they're using concurrent antimicrobials. Has anyone ever heard that before, that you're not supposed to, you shouldn't be relying on your birth control? Yeah, exactly. And that actually has to do with hepatocellular cycling. So what's happening actually is the way your CYP enzymes work in your liver. It changes when you're on antimicrobials, right? Because they sometimes interact with your CYP enzymes. And that actually can mess with the way your estrogen and your progesterone are cycled through your liver. So in essence, it makes your OCP ineffective. So tell all your patients, please do use a second method of backup contraception. Okay. Once again, if they're with concurrent enzyme inducer, kind of along the same lines. So if we're affecting the CYP enzymes that are helping to cycle the or progesterone in OCPs, we can have a problem there as well. Okay. Fibroid tumors, this can exacerbate the issue as well. And then edema. So our patients that have congestive heart failure and have problems with edema as it is, sometimes these can also cause fluid retention as well. So once again, just a cautionary statement, not a complete contraindication. Yes, Dr. Earl?
I will also want to point out, smokers are going to be at increased risk
Very true. Yeah.
for thromboembolic risks around contraceptives, especially as women age. So the cigarette smoking with contraceptives can spur a greater risk in older women of childbearing.
Very true. Thank you for pointing that. So obviously those were our scary side effects. These are kind of the run-of-the-mill normal ones that we see. And basically we're going to talk about what they are and how to manage them. So for estrogen excess, sometimes we can see nausea and breast tenderness. We can get headaches. We can also get cyclic weight gain. Some ways that you can manage this, estrogen content, or you can either then you can also have something else called dysmenorrhea, menorrhagia, or uterine fibroid growth. Once again, we can decrease estrogen content in our OCP, or we can consider an extended cycle or continuous OCP as well. And once again, progesterone only builds our estrogen material. For estrogen deficiency, we will have some vasomotor symptoms. Does anyone know what vasomotor symptoms are? Yeah. So flushing, hot flashes. Basically, you can think of those. You can think of those vasomotor symptoms as some of our patients in menopause. So sometimes those symptoms can co-align. You can also have nervousness or decreased libido. You might want to increase your estrogen content in the OCP at that point if that was the issue. You can also have early cycle, days 1 through 9, breakthrough bleeding or spotting. Once again, increasing the estrogen content in the OCP can get rid of that. And then amenorrhea. So that withdrawal bleeding stops. We don't have a period. Once again, you can exclude pregnancy and you can also increase the content if desired of the estrogen. Once again, this will stop the woman from getting a period. And if they desire that, you can move forward with that option. Okay. And then progesterone. So progesterone excess, some symptoms would be increased appetite, weight gain, bloating, and constipation. You can decrease the progesterone content in the OCP. You can also have acne, oily skin, or hirsutism. This is where those less androgenic progesterone options come in. Androgenic meaning they're more like testosterone. So they have some of these nastier side effects of acne, oily skin, and hirsutism. So going with those less androgenic progestins can actually improve this for patients. And you can also decrease the progesterone content in the OCP. Depression, fatigue, and irritability side effects can also be fixed. Okay. Progesterone deficiency, so we'll get dysmenorrhea or menorrhagia. Obviously fix it by increasing your progesterone content. You can consider an extended cycle, or you can consider a progesterone only or IUD. If they have late cycle, breakthrough bleeding and spotting, once again, just increase the progesterone content. Okay. All right, AB is a 21-year-old female who would like to try combined oral contraception for the first time. She indicates she likes to travel and would prefer one of those birth controls to let her manipulate when she gets a period, which is the following type of combined oral contraception which she recommends. Does anyone want to shout out the answer? Perfect. Exactly. So that one is the easiest to manipulate your cycle. Right, the next one. You decide the best option for AB is a monophasic combined contraceptive. Which of the following would you prefer AB to expect? How many think A? B? C? D? The C have it, so increase likelihood of breakthrough reading. And then which of the following are major risks associated with combined contraceptives? Please select all the apply. I'll give you a few minutes and then we'll go through the answers. Please think A. B. Okay, C. D. And then E. Okay, perfect. All right. So obviously endometrial cancer, we see a decreased risk of that with use. Stroke, thromboembolic events, myocardial infarction, ectopic pregnancy, no, right? Because that is actually decreased with contraceptive use. And then thromboembolism, once again, thromboembolic events, so really. All right. Now moving on to our mini pops. So once again, only progesterone, there is no estrogen in these. They are actually a lower dose, which once again is why you'll hear them referred to as mini pops. Okay, and they do not have placebo pills. So all of them should be taken at the same time. The biggest point with these is adherence. Adherence. Take the same time every day. If you are over 3 hours late, then you should use a backup contraceptive. And you should use it for 2 days. I have seen people not adhere to these and be like 5 minutes off even, and they will get pregnant. So it is super important.
Five?
But it does
No
happen.
thanks.
And unfortunately, this is not unfortunately, I
You would be
should
so
say, but it's very
pregnant.
popular for people that just had babies.
What?
Because it's
Sydney,
good for breastfeeding. Does anyone know
so
why?
fair.
Is estrogen contraindicated for breastfeeding?
No.
No, right? So what could be the reason?
Don't want to decrease the milk supply.
Exactly. Yeah, perfect. So what she said was milk supply. So estrogen can affect milk supply. So a lot of people don't like to use it. If you have a baby at home, I don't know if anyone does. You know that breastfeeding and breast milk production is super important. And it's painful and it's time consuming, right? So you do not want to lower that supply. So a lot of them will go for the progesterone only pills. Now, if you just had a baby, most of the time you don't want to get pregnant right after you had a baby, right? 8 years. I can't stress it enough. And then also some patients actually prefer these because it's a low dose progesterone, so it has less side effects associated with it. Okay. Any questions so far? I know I feel like I'm throwing a lot.
Okay, can you explain that again about the breastfeeding?
Yeah, so, it's not a safety issue necessarily. A lot of patients prefer to use mini pops because estrogen content in contraceptive actually decreases milk supply. A lot of women struggle with milk supply as it is. So using something that's going to decrease milk supply could be really harmful to them. So progesterone only pills are a lot of okay. And then coming down the pipeline, so I'm gonna let you guys probably see. Oh, question.
Right?
Okay. There's actually a new FDA approved oral contraceptive called Norgestrel or Opill. It's gonna be OTC. So then we'll be able to get it OTC and it actually will be legal here in Maryland. So something down.
It's gonna be this.
All right, question.
Yeah, sorry, this is going back a little bit for the estrogen, for the combined OC, side effects. You have like, it says estrogen deficiency, whatever. Is there any reason that they're grouped, like, under like estrogen deficiency, like, you caught like road needs, and you need to know that, or is there some sort of logic to that?
So I see what you're talking about. So these right here, there's different management styles than it has these.
That one sort of
God
makes sense.
bless.
What about the first one? Deficiency.
So the estrogen deficiency, that was just me not paying attention.
Oh, okay, so we don't, all we need to know is kind of that this is what we do.
For your exam
Right,
purposes,
what we.
you are not going to need to know this in depth of how to manage these. This is more an FYI for you. It's something that you can use in your practice in the future if you do deal with women's health. But for exam purposes, this is not, I'm not gonna be asking you,
Thank you.
how do you manage this one? Do you want to do this?
Right,
Yeah.
that was what I was.
Yeah. There you go. Question?
Yeah, I was just wondering, like, how much, of a groundbreaking politics event is like, or how does it in here on oral contraception? Like, is that enough to not go to patient, certification on it, or?
So there is actually a resource from the CDC that provides more guidance on who is absolutely contraindicated for OCTs. Because it really is based on, like, for instance, smoking history, if they have a cardiometabolic history, this could be a no-go for them. To answer your question, it does raise risk, but other factors with the patient demographic are going to enhance that risk. So it's really patient specific. But there is a resource from the CDC that is, it's something that you guys want to look into further, you can see it. It's actually really nice. It kind of walks through all the patient demographics, and how to choose the OCT for someone. And if you should. Does that answer your question?
This new over the counter. That could be.
Yep, so any progestin only pill is going to be very strict, and you actually raised a really good point about some concerns with this new OTC. In the patient counseling portion, because obviously a pharmacist can't counsel you if you just walk over to the counter, like wherever, grab it, and then be on your way. And it could potentially be a 12-year-old girl that grabs them and checks out with it. So that is something that we have to consider, and I think it'll be a movement probably in the pharmacy sector to put it behind the counter, so to speak, to force patients to come up and speak to a pharmacist. But it's a really. So if we're thinking about our cardiometabolic risk and our thromboembolism risk, estrogen content is a little bit more risky. Progestin only pills don't have many adverse effects, and certainly not those safety concerns that estrogen content do. So that's a big question. Yep.
Actually, to answer your question, I actually, had it on the movement, but even can't be on estrogen. So that's why they did the thing.
Any other questions? Okay. So missed doses, what do we do if patient tells us that we missed a dose? So combined oral contraceptives, if they missed one dose, tell them to take it as soon as possible and to double up the dose the next day. They don't have to use backup contraceptive if they only miss one dose, and they take it as soon as possible and double up. 2+ missed doses, take as soon as possible and back up for at least 7 days. And then if they miss a dose in the 3rd week, they can finish the pack, skip a placebo week, and start the new pack. One thing I would like to say is that these are general instructions, and it's really going to depend on the estrogen content of your contraceptives. So always look it up just to double check. These are just general guidelines. Okay, and then our pop, take the missed pill ASAP, even if double the dose, and then back up birth control for 2 weeks. And once again, general instructions, please always look at the OCT content. Always look at return to fertility. So our combined oral contraceptives, there's a delay in ovulation for 1 to 2 weeks. And then 2 to 3 normal menstrual cycles should be gone through before attempting contraception. And then our mini pops obviously returns. So another reason why some people like that. Right. And another knowledge check. WT is a 31-year-old female with a past medical history of schizophrenia, depression, anxiety, and non-adherence to medications. She's required to stay about 12 months. She is a single mother to a 9-month-old that she is weaning off of breastfeeding. She indicates she's not ready for another child. Is the progesterone only pill the best option for her? Okay. I'll give you a minute. How many people think it's A? B? C? D? Okay, you learned something. So no, she has a history of non-adherence to medication. Obviously, she could get pregnant very easily if she gets one of these pills. Not a great option for her. Yes, she is breastfeeding. That's something we should think about, but obviously an unplanned pregnancy is the worst of those two evils, especially for someone that indicates they are not ready to have another baby. So that is correct. Now we're moving on to non-oral formulation. I know I stopped to ask for questions, but is there anything else before we move on to the next section? All right, so our first non-oral option is the transdermal patch. It's called Xulane. It has ethinyl estradiol and norelgestromin. I'm sorry, this name's adverse effects. Breast tenderness is the most notorious side effect of this one. Patients can apply it to the abdomen, upper arm, upper torso, or their butt. One thing that you should note specifically for this one is it's less effective in women that are greater than 90 kilos. Do not use. Clinically proven to be less effective, so not a good option for those. The return to fertility is just like our combined oral contraceptives. And those are kind of the main benefits. One thing I will say, if you have a patient that has eczema, that can't have a good spot to put the patch, maybe not a good option for them. If you have someone that is a high schooler on a swim team, probably not a good option because it's going to keep it continuously wet, it's going to fall off. So there's some little things to do. If the patch were to fall off and it's less than 24 hours, you can reapply to the new place or replace it ASAP. But you can reapply the same one. If it's greater than 24 hours, or which is most likely the case, they don't know how long it's been off. Apply a new patch and use that day as the new patch change day. And once again, back up contraception for. Any questions about this one? All right, our next option is the vaginal ring. So we have two. We have the NuvaRing and the Innovera. Some notable side effects that this one has is vaginal discharge and headaches. Those are the most notorious. Obviously, there's other things that can crop up, but these are what people can do. To apply it, you're going to insert intravaginally. Some patients are not comfortable using their finger. So the one thing that they can do that is pretty cost effective too is actually use a tampon applicator. You can actually just put it inside the tampon applicator and administer it that way.
Huh.
So that makes it pretty easy for patients.
Oh,
For our NuvaRing, it's 3 weeks in and 1 week out. Or 4 weeks and then you replace with a new one. And if they do that, they won't get a period. So it really depends on patient preference. If they want to see that period, it makes them feel less anxious. Then 3 weeks in, 1 week out. If they would rather not have it, 4 weeks in. Okay. For our Anavera, this one is 3 weeks in, 1 week out, and they actually reuse the same ring for an entire year. So there is no new ring. It actually has like a little carrying case that you take it after 1 week, you put it in, obviously wash it.
Don't lose it for 1 week.
It comes in a little kit.
Oh, so you're
It's
sort
like
of,
a plastic
like a retainer kit.
Yeah, it's a retainer, kit,
Yeah.
but
Oh, okay.
looks like a retainer case, but
Yeah,
for
yeah.
the ring.
I love that.
Good to know. Something to keep in mind with this one is if it actually
Giving
does
you the
become
kind of-
out and it's less than 3
You use
hours,
that?
they can just
Yeah,
rinse
try
it and reinsert.
I
If
don't
it's
think I
greater than
like-
3 hours,
I should not
it's
stay.
also supposed to be so do is rinse, reinsert, back up for 7 days. Week 3 throughout the ring. Obviously, this is for our new ring. To start the ring, get a new ring to start a new period, or you can get a new ring within 7 days from the time the ring is. And then once again, return to fertility, because that is a good point for your patient that they want to know. Is that it's like combined. All right. Then our depot shot for depot Provera. So there's two routes. There's the
For the patch and the ring, are there sort of like the same exact like contraindications and everything as the oral contraceptive pills with like the thromboembolic risk and things like that?
yeah, so anything that has an estrogen content is going to carry those contraindications and those risks. That's a good question, but yeah, even though it's not necessarily readjusted, it's still estrogen content and it's still something that can.
It's just a ring.
That's your question?
It literally is like this big and you fold it and shove it up. A couple of those came like even the size of like and it's like flexible.
Can you repeat the question? Can't hear it.
Okay, so the question was, is a 1 week out, does that affect fertility anymore because of the up and down of estrogen? I don't think there's any evidence.
Yeah, I think that's, yeah, so if you're following either one of those, they would have the same failure rate or, I mean, it wouldn't be significant.
I think she's saying like the return to fertility, like infertility. I don't think there's, I've never seen anything.
Oh, yeah,
I've never seen anything. But that is a really good question. But we'll look into that. All right. Any other questions? So then our depot shot, like I said, it has different, so it can be intramuscular or IM, and it can also be sub-Q or subcutaneous. And this is I think it's sad of why some people might prefer the sub-Q route as a patient preference.
Smaller needle. Smaller needle.
So it's actually because they can do it themselves. So some people would rather give themselves a shot than someone else because they can control it. So for that one, that can be a patient preference thing for the sub-Q because it is self-administered. Okay. And then another thing to really note with these is people complain about weight gain all the time with contraceptives. This is actually the only one that's been proven that weight gain is an issue.
Yeah,
Okay. So this one is consistently associated with weight gain. So if you have a patient that's terrified of gaining weight,
Men do the studies.
this might not be the best option. Or if it's someone that, you know, weight gain is an issue for them in general, maybe not the best option. Okay. The IM dosing is 150 milligrams every 3 months. Sub-Q is 104 every 3 months. Once again, dosing for IM is every 13 weeks. For a sub-Q can be 12 weeks. Okay. Our sub-Q also has another FDA approved indication. So it is pain associated with endometriosis. So if you have a patient that also struggles with this, the sub-Q formulation can be a good option. Okay. So the benefits of the Depo-Provera, so our IM has a reduction in menstrual blood loss. This is actually something that it's most commonly marketed with, is that decreased anemia for patients of heavy periods. Okay. And then obviously with our sub-Q, there's a decreased risk of endometrial cancer, which kind of goes. For our adverse effect profile, so we can have amenorrhea with breakthrough bleeding. There's also increased risk of atherosclerosis. And once again, the weight gain and osteoporosis is a really big risk with this one. And we'll talk about that a little bit more next slide. As far as initiating these, so injection after 13 weeks, we have to do a pregnancy test prior to injection. And then if after 14 weeks for our sub-Q formulation, we want to do a pregnancy test prior to injection. And once again, self-administered, because sometimes patients like those better. Okay? Yes.
So there's a lot of stuff on the internet about, well, I know there's a lot of stuff on the internet. There's a lot of stuff on the internet about hair loss with Depo-Provera and people developing significant alopecia as a result, and like a full
Yeah,
blown
that
hair
is the
loss.
thing. That is the thing.
And I mean, it has been substantiated and everything.
Yeah, that it's very minor, but that has been seen hair loss. but, very low incidence, very, but that has been documented. from what I've seen.
Ask the women to get it. It's not minor.
Fact, but it's a very small.
Yeah. No thanks, that and your bones are gonna break. Yeah.
I don't care about that.
All right, so osteoporosis, this is
Did you
considered
say
the
6
biggest
feet,
difference
6
in this one.
0?
So how does it occur with the
Wow.
shot? So it
There's so many
inhibits
other choices.
anaerobic secretion, which then is going to increase our ovulation and estrogen production, obviously, but it also decreases our bone mineral density. When we see this happen, there's actually a rapid decline in bone density within the first 2 years of use. And we actually only use this for 2 to 3 years. The ACOG guidelines actually recommend that we check vitamin D levels, supplement with calcium and vitamin D as needed or it's typo. They also recommend smoking cessation, exercise, and alcohol moderation, and they recommend against DEXA scans and discussion. So the basically, the only thing really is limiting the use of this. This is not a long-term solution for contraception, because of this osteoporosis. It is handy for patients because it's long-acting, they get a shot when they're done, but it can't be a long-term thing. All right, knowledge. Which of the following are available formulations of non-oral pharmacologic contraceptives? Well, this is a pretty. A. Anyone for A? B. 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 All right, so sub Q, yes, right? Do we have an intravenous? No, yes, please don't. say that. Intramuscular, obviously we do, and then our transdermal patches. Obviously, our sub Q and IM injection is our Vera, and then our Xulane patch. Okay. All right, JM is a 20-year-old female with a past medical history of anemia, menorrhagia, asthma, and eczema. She is interested in a birth control option she does not have to take every day. Which of the following would be the and then keyword there is this. That was a over here. Perfect. So the Depo-Provera, no one heard what she said. The reason is, once again, she has eczema, right? Maybe a patch is not the best option administration wise. And then she also has menorrhagia. So she has a really heavy flow. And she has probably anemia that's associated with this menorrhagia. Depo-Provera has been shown to help with this. So that's what makes it the best option. Does that make sense? Yeah.
So this can only be used for 2 or 3 years. Is there? Will the patients go back to having the same symptoms once they stop it? And switch to another person?
That's a good question. So, I would say yes, it's having some kind of experience. And then what's the Unfortunately, it's not one of the Great. Now on to our long-acting reversible contraception, affectionately termed MARC. The subdermal implant. So some people have like horror stories with these.
Yeah.
The reason why is because the old implant did not have the property to be able to be tracked if it moved, which is why it's no longer on the market, which sounds really scary. That's why this one though, it does have the ability to be tracked. It has the barium sulfate here for localization. I just like to reference that because I feel like I've met a lot of people that have that horror story of, I couldn't find my implant. That is not a thing anymore, thank God. That's not what we did. So if you can find it, there's the verification. Okay, it's called Nexplanon. As you can see here on the arm, little tiny thing that goes in your arm here, that's the applicator right there. It's FDA approved for 3 years, but it may be effective for 4 years. So if we have a patient that wants something that has a really long duration of efficacy, and that's not an IUD, because those can be a little painful sometimes for patients to get put in, this would be a good option. Some adverse effects, pain following insertion, obviously we're putting an implant with the arm, and then tendinencies. So if we have a patient that already has this issue, maybe not a good one to choose. Okay. Once again, our barium sulfate here to help us find it in the rare occasion that it does trouble. I don't want to scare people, but it does happen. Fertility returns immediately, which is also a nice one with this one. And then it's potentially less effective in obese women. I think potentially, because there is some evidence that maybe it's not as increased efficacy. So there was a choice, something called the Choice Project, where people could choose their own contraceptive method. And 1/3 of obese women actually chose the implant, and they saw no differences in effectiveness found. So there could be potentially less effectiveness, but there is some data out there that says that. So that's going to be up to your clinical decision. The CDC says it's the safest contraceptive in HIV positive women. In addition, obviously, to condoms to protect you from STDs. Great. Our next one is our IUDs. Okay. So the one thing I like about these is they all have these like super pretty whimsical names, right? Marina, Kylina, Loletta, Skyla, and then we have Paragard, which is not good.
So
It will
it's
keep
getting
me
by the way to the generics for the orals, like Jolisa.
Or less.
No. Girlfriend's name,
That is like the one thing where
I was probably waiting on it. It's so good. I was like, okay, I'm on the radio. I'll take your girlfriend.
The main difference is certifications for. So our Marina is for 5 years. Our Kylina is good for 5 years. Loletta 6. Skyla comes in at 3. Some things to note when we initially put them in. The first 5 days of menstrual cycle plus backup contraception for 5 days after we put them in. Postpartum, if we put them in, we want to make sure it's a minimum of 6 weeks to make sure that this uterus is fully involuted. And then if it's post-abortion, if it's the first trimester, you can put it in immediately. If it's second or third, once again, a minimum of 6 weeks because we want to make sure the uterus is fully involuted before we stick that IUD in. Okay. Okay. And then our copper T, which is the Paragard, which is once again not so pretty, but it's 10 years. You can put it in at any time for the initial here. If they're postpartum immediately or the second month, and then post-abortion immediately after. There's another caveat with this one because it's used as a emergency contraceptive, which we'll talk about a little more. Okay. Some adverse effects is IUD expulsion, perforation, spotting, cramping after insertion. Obviously, these ones up right here, that's a little bit scarier. And then right here is our pictures. So this is what the pretty named ones look like. And then our copper T over here is literally made from copper. Yep.
Based on what's on the slide, the copper one looks like it's better in every way. Are there like downsides to that one in particular?
So that one actually, that one has a higher risk of the perforation, which is the downside. Actually, it is actually our living naturals that have a higher risk. I think it's actually. I think of this. Bring it back to you. You're gonna think. All right. So with insertion, the other thing is to use OTC NSAIDs because they do hurt when they're inserted. I know that there is some controversy as far as pain relief with IUD placement. Some people don't think that the OTC ends are enough, but for right now, that is the guidance that we have is to use OTC. And then fertility wise, comes back right afterwards. Does anyone have any questions besides the hard questions? I saw her first and then.
No, I'll just say that the copper IUD is contraindicated in copper allergy or anybody with Wilson's disease.
That could be a point.
Hasn't the Mirena ID been FDA approved up to 8 years?
So the labeling has, well, actually data has shown effectiveness up to 6 years, but the FDA labeling still specifies.
Okay.
So that's why I have the little asterisk there. It's just because, like you said, there is an effectiveness that's been shown in data up to 6 years, but the labeling still does say 5.
Okay.
So we're going by package inserts, 5 years. Any other questions?
Is there any, like, is that a continued conversation about like changing the pain medication like prior, or is it just becoming like a provider preference?
I feel like for right now, it's provider preference. I haven't seen any guidelines actually specifically on what they do, and it's to say use OTC instance. But I think it is something that's more to light. It's more like complaining about the pain associated with IUD placement. But for right now, NSAIDs and OTC strength NSAIDs are the mainstay of therapy.
Okay, thank you.
Any other questions?
I guess I just want to understand how the injection, like how it's going to work, and then like all of a sudden it's not work. Like is there like a decrease in its efficacy or the time of the next dose, or like how does it increase that in the drop?
Can you repeat and like what do you mean by efficacy?
So like you have to get it every 2 weeks or every 12 weeks. So I just don't get how it can work fully, like 100% prevent pregnancy, and then like the next day not.
So the first thing is to think about what type of contraceptive. So if you remember what type it is, like what is the compound that's in? So what is, okay, so it's progesterone, right? Now obviously it's going to be obviously longer extending than like any pop, right? Because of the pregnancy here. But fertility does tend to refer more quickly than those progesterone only, fertility returns the only thing we need. Responses in yeah, that's the best answer. I'd say it's just looking at that. This one. So fertility, but technically it's actually any other questions? Okay, our next knowledge check. So JM is a 23-year-old female. Great. I'll just read it to you. Is a 23-year-old female with past medical-related anemia, menorrhagia, and asthma and eczema. She was on Depo-Provera for 3 years. She wants to continue with long-acting contraception. However, knows she should not continue Depo-Provera because of concerns for bone health. She heard about an implant you can put in your arm and asked you if you think that would be a good option. Choose the best response. Obviously, if you remember, our next implant has a notable FMC side effect, so maybe not the best option with someone with that has a menorrhagia. So potentially looking at it different. Now on to emergency contraception. So, like I said, we have options on copper IUD, Paragard, which I mentioned previously, and we have Plan B one step, which is our levonorgestrel containing compound. And then we also have Lorcrystal, which is something to note with the Plan B. So originally we had Plan B and then Plan B one step, right? Plan B is no longer on the market. In preference to the Plan B one step. Does anyone want to take a stab at why that might be? Perfect. So why would you take a twice a day emergency contraceptive when you can just take it?
One time,
It's also probably a safer bet for the fact that we'll know people will take it once.
like you have
versus
both
twice.
raised.
So, that's why I thought. Okay, and there's also something called the
The one taking it.
which we will talk about. For IUDs, they're the most effective out of all our options. They have to be inserted within 120 hours of protected intercourse. But it is an off-label use. And copper interferes with sperm transport and fertilization of the egg, which is how this actually works. So that's how it helps with the fertility. Then our levonorgestrel, it's 1.5 milligrams once. You can use it within 3 days or 72 hours after unprotected sex. It's available over the counter with no age restrictions, and it can be purchased by either a man or a woman, which has been controversial in the past. But it is available to both sexes. Adverse effects of this one, the most notable is the nausea and vomiting, which for something that you're taking by mouth is not the best. You're trying to prevent pregnancy. Irregular bleeding can also happen and a delay in menses for more than 7 days, which once again, if you're using emergency contraception, can be a little bit scary if it's late. So something to definitely tell patients that they stop by and talk to you about emergency contraception use, just to give them a hint. Okay. It may be less effective in overweight or obese women, something to consider. It's also ineffective with repeat use in the same menstrual cycle. So if a patient has unprotected sex in the same menstrual cycle, they use it again, it could be potentially ineffective. Repeat that. Other brand names, because I know Plan B is kind of what we think about most. There's a whole laundry list of them. Take Action, My Way, Option 2, Repentisa, Afterfill, My Choice, Aptera, etc. And there's many more.
Back plan. Yeah.
Amazon for like
And then
Oh, that's so
our
much
Google
cheaper.
Crystal or Ella. So it's 30 milligrams once.
Never bought anything.
Company wise, once again, within 5 days, or 120 hours. The downside of this one, and I call it downside because it's dependent, is it requires a prescription. So how likely do you think that someone who has unprotected sex is getting a prescription within?
Never.
So that's why really Plan B is usually our first resource, right, because it's OTC. But yeah, this one requires a prescription, which is kind of which is why it's not very popular. Some adverse effects. Headache is the biggest one with this. 25% of patients report headache with this one. Dysmenorrhea, nausea, and abdominal pain also can go into play here. It is the next best option in overweight or obese women. If IUD is not an option, this is the one that is recommended. And then you should wait 5 days after use to initiate a hormonal contraception if you are considering that in the same visit with your patient, because it requires a prescription. You will be seeing them in a setting, give them a prescription. So you can consider this as well. Just remember to wait 5 days. Okay. And it is actually a selective progesterone receptor modulator. So it's a lady population, so it's a little bit different than our approach. And then the last thing is the Yupsy method. Has anyone ever heard of this? Yeah. Okay. Fun fact, it actually was developed in the 1970s by Albert Yupsy, which is where we get the weird name. It was it's the first PO method of emergency contraception. And the reason why is because you can actually use your own contraceptives you have at home to do this. So the one thing I will note, 75% effective up to, so it's not our most effective option, but it is convenient. So that is the one I'm, but I will preface it by saying, not the most effective. Okay. You can administer it within 72 hours of unprotected intercourse, and you can once again utilize the patient's current combined. The dosage is 200 micrograms of ethanol estradiol, 1 milligram levonorgestrel. You take it 2 doses 12 hours apart. Like I said, it's really Adverse effects is nausea, vomiting, spotting, restlessness, and fatigue. They should all sound a little bit purpose. They repeat themselves. But yeah, for this one, just if a patient does not have another option and cannot access an alternative, this is something they can do, but it is not. All right. That concludes contraceptives. That was a lot of information. Anyone have questions? Before we-
That's just my own curiosity. There's been a lot of talk about making birth control over the counter, period. Has there been any progress on that, or?
So I guess the biggest progress is really that we do have that mini pop coming out that is over the counter. I don't, my opinion, I don't foresee estrogen containing oral contraceptives to be over the counter just because of that risk. And for instance, most patients don't realize if I smoke, I'm more at risk for thromboembolism. So it really does require someone with more authority and medical knowledge to prescribe those. But I do think that our like mini pop pills likely will go.
Another thing they're doing is credentialing pharmacists to be
Yeah.
providers for oral contraception. So,
Yeah.
not every pharmacist, but you have to take certain credits for CD or whatever. And then you can, as a consumer, go to the drugstore without seeing a license from primary care provider, get contraceptives that way. So that's kind of how they're broadening access. And, the other thing is just from a policy standpoint, making it accessible. Anyone with health insurance, with few exceptions, can get contraception at no cost under the Affordable Care Act. So, that kind of takes away that barrier to contraception. as well.
In Maryland, yeah, that law has been passed, and pharmacists can potentially be prescribing. Or not. So it's easy, I think, right? Even he's right. So yeah, that is coming with one, and you'll be seeing that. So any other questions about contraceptives? Before we move into fluoridation? So let's talk about eligibility. So for a medical abortion, this is with obviously pharmacologic therapy, basically, they have to be at less than or equal to the 7 days gestation or around 1 year. For this to be really effective and recommended. It is not recommended in confirmed or suspected ectopic pregnancy. Does anyone know the agents that we normally use for that?
Methotrexate.
Great. It's also not recommended if there's an IUD in place. It is not recommended if there's current long-term systemic corticosteroid therapy, if there's renal failure, if they have a no coagulopathy or are open anticoagulants. They have inherited porphyria, or they're intolerant, if they have intolerance or allergy to the agents that we would talk about. It might be preferable the uterine aspiration in those that have uterine fibroids, or they have congenital uterine anomalies, or intracoital. So for those patients, medical abortion is less preferred. So for our combination mifepristone and mifepristone, it's called Gizmo, so I'm pronouncing it right. The mifepristone dosing is 200 milligrams by mouth, 1 day 1. And then the misoprostol dosing, they take it 800 micrograms usually on day 2 or 3. And it is the FDA approved agent for use in medical. Okay. This is actually preferred by the World Health Organization because it is more effective. So that is why it is preferential treatment. And you can take this within 24 to 48 hours post mifepristone dose, which is why it says 2 or 3 days. Okay. As far as adverse effects goes, we have nausea, vomiting, diarrhea, headache, dizziness, fever, hot flashes, and chills can be associated with this one here. It is the preferred method by the American College of Obstetrics and Gynecologists. And patients should be counseled that they will have bleeding and cramping. So that is normal. And then in the case that it does not work, they should be counseled for the teratogenicity. And that is why we have the mifepristone drugs program here, because of this. And if this is unsuccessful, there could be this potential. Okay. And then once again, it's something that also is still a debate. NSAIDs morphine, that is what is recommended by ACOG. That is what we have to go for guidance. OTC. Okay. Now, as far as the FDA REMS program, you have to be certified to prescribe. So you have to complete a prescriber agreement form if you want to prescribe mifepristone. The other caveat is that you have to be certified to dispense. Now, this is actually an improvement because before they couldn't come to the pharmacy to get this agent, they had to actually take it in the office. So now pharmacies can be certified to dispense. The pharmacy has to complete the pharmacy agreement form, or once again, dispense under supervision of the certified prescriber. So this actually was relatively new to increase access, because obviously sometimes this is not how the patient. That's what I'm putting. So then there's also the patient agreement form portion. You have to review it and sign it with the patient, and then you have to provide the patient with a copy of the agreement that's signed, plus the medication guide. Once again, this is really because of that teratogenic risk, why we have this program. But there is the plaque that was given for this part here for issues, but they have tried to change it.
Okay, let me also call your attention, while FDA has, kind of very broad authority over nationwide administration of drugs, now in the post-Dobbs era, it's going to be state by state as well. So each state, depending on where you're practicing, is going to have certain guidelines as far as whether you're able to prescribe and how long, how far into pregnancy and that sort of thing. I mean, it's wild, wild west, honestly. You have the mail order stuff now where you're trying to go across state lines and then all these court challenges. So, I urge you just to be aware of not just the federal REMS, but what the laws are in the state in which you're practicing. Because that's, liability you don't want to have if you're going against state law.
I think in Maryland, though, that stands.
Yeah, we're fairly women's health friendly state.
So here, that's only your guidance, but that is a good point. Yeah.
And the Attorney General's office, just a couple years ago, might have been more than a couple, but it's recent, came out with an opinion that PAs you cannot perform medical abortions, but you can prescribe the mifepristone, and you can prescribe for medical abortions. Right, and there's been a lot of stuff about it, like whenever you go to the legislature and like the right to life, people are always there saying that it has all these harmful side effects and this and that, and they're not publishing it, and they just proved this past year, within this last year, that all of that was false.
Quite safe. And where you run into problems is when you try to do it with just the one drug. If you go with misoprostol on its own, you can get some really unfortunate outcomes. So the combination is actually quite effective and well tolerated.
I don't have a question, but I'm pretty sure recently there was a bill passed in Maryland that mid-level providers can do abortion. They have to receive training for it, but the governor was withholding the training that was allocated towards that. So it was approved.
May very well be. I haven't followed all the laws this past session so far, so I will have to check it and make sure and see what he signed and didn't sign.
He vetoed it, but it still ended up passing.
So they overruled his veto.
Yeah, but then the funds were withheld, and I don't know what happened after that point.
Oh, yeah, I did hear. I did hear.
So it's getting dicey is what you're saying.
Yeah. But legally you can.
Do it.
Then for our misoprostol, which you can use by itself, but it is less effective. Which is what. You're gonna do 800 micrograms vaginally, sublingually, or buccally. Something to note with that is that if you do the vaginal route, there's less GI side effects, which can be very troublesome to patients. So just something to keep in mind. The sublingual and the oral have similar side effects. We don't actually do PO. The reason why it's actually less effective, so that's why you'll see vaginal sublingually. You'll repeat every 3 hours for up to 3 doses. Okay, and once again, I bring it home. Very efficient. It is not FDA approved alone with medical abortion. So obviously, in combination, it is approved, but not by itself. There's no FDA approved. Adverse effects, nausea, vomiting, diarrhea, once again, GI side effects, less with the vaginal route. Headache, dizziness, fever, hot flushes, and chills. ACOG, once again, just this as the alternative, not the primary agent. And patients should be counseled when bleeding, cramping, and teratogenicity in the event of unsuccessful medication abortion. So once again, because it's less effective, this is more of a risk. Okay? And it's more of a risk that a patient will actually have to undergo something. And then NSAIDs for pain, again, OTC NSAIDs. And repeat doses can be given for ongoing pregnancy following medication abortion. That is something that. All right. Just some brief intro today. So obviously in 2022, we had our reversal of Roe v. Wade. In April of 2023, the Texas District Court judge did order mifepristone to lose its FDA approval, which is never following the lawsuit. The Supreme Court stated in its ruling and is looking into it further. So it is still FDA approved. It has not lost its approval. The Maryland Department of Health in June of 2023 partnered with University of Maryland actually to stockpile mifepristone. And we actually have 35,000 doses of mifepristone for $1.1 billion in doses of mifepristone stockpiled in Maryland.
Oh my God.
In result of this. So we have stockpiled that. Question?
Yeah, this might be dumb, but why, what's the point of the stockpiling?
I'm sorry.
What's the point of the stockpiling?
But
Because
there's
of this
access.
FDA approval is pulled, it will affect,
The cost?
no, it will affect the
Production.
manufacturer.
Yeah, they won't make it.
Oh, so there just won't be any more made?
Yeah.
Why couldn't it still be made and then use off label?
They want to pull the whole FDA approval, as in like, this drug cannot be marketed anymore in the US.
Oh,
So it's not an approved indication.
that's what I thought.
It's actually like the whole approval throughout the whole country. So that is why Maryland is like that. Which if you think about it, 35,000 doses is actually not that much, right?
No.
But, yes. But update, the Supreme Court in March of 2024 actually signaled, based on court documents, that it will likely allow mifepristone to continue to be available because the basis of grounds for this was not proven. So this will likely not happen, just FYI.
Confused about the dosing of the combination. Does that come in single? And it is approved, but the.
Yeah, so okay, so this one, it comes in combination, but these are two different routes, right?
Oh,
And they have to be taken on separate days.
so why, if that's approved, if the other one isn't, but it's in this one.
So the approval is actually the approval for the combination, it's not for them separately. Like it's approved for the indication of medical abortion together, but the misoprostol is not approved separately. Does that make sense? I know it's low. Yes,
And why would Why use misoprostol on its own?
So that is because we have some kind of conversation of not using mifepristone, and sometimes it's not available in certain areas. And because we do have those state laws that regulate how it can be prescribed, how it's accessible. So if this is the more accessible option, just this by itself, and this is all the patient can get, then this is what we do.
And remember, misoprostol from last semester is also used for GI, specifically NSAID ulcers. So, there's really no threat to remove that from the market because, you know, for all of its other uses, you would get a big thing, whereas the mifepristone is pretty much exclusively used for medication abortion, so anti-abortion lobby is really targeted that.
Any more questions? Right, which of the following agents are used for routine medication abortion in less than or equal to 70 days gestation? Is it mifepristone alone, is it misoprostol alone, methotrexate, or mifepristone misoprostol combination? Anyone want to- C&D.
Oh, good.
I forgot my like all of my. That was fun. But yeah, so obviously we don't use this alone, we only use it in combination. And then methotrexate, that is for our disease. All right, switching gears, fertility treatments. The exact polar opposite, but we're gonna go. All right, so do you have any questions for me on switching gears? So this represents the WHO classification of anovulation and WHO being World Health Organization. So you know. So there are 3 classes. There is class 1, which is hypothalamic amenorrhea. The way it presents hormonally is that they will have low or normal FSH, low estradiol, decreased hypothalamic secretion of GnRH, and decreased pituitary responsiveness to GnRH. Some possible reasons for this is excessive exercise or low body weight. So basically their period stops. The next classification is class 2, or I'm gonna butcher this, normogonadotropic normoestrogenic anovulation. As this suggests, gonadotropics and estrogens are normal, so they range normal. There is a decreased FSH secretion during the follicular phase, which is thought to be a component of this. And the possible etiologies, we'll really see this in polycystic ovary syndrome. So this is really where we see the class 2. Our class 3 is hypergonadotropic hypoestrogenic anovulation. Once again, low estrogen, hypoestrogenic anovulation. Possible reasons for this is primary ovarian insufficiency, gonadal dysgenesis, and just to expand on that a little bit more. So usually this one over here actually presents as early menopause, because we have an absence of ovarian follicles and premature ovarian cancer. So that's where we get this one. We'll see premature menopause patients. And then the last one here, which is not actually classified by the World Health Organization, so I just labeled it other, is hyperprolactinemic anovulation, which has to do with prolactin. Just a little background. So our oral fertility agents, the first one is clomiphene, also known as Clomid or Serapine. It's a selective estrogen receptor modulator, or a SERM. Okay. You might also hear of SERMs being tamoxifen and raloxifene. We don't normally use those because they're not as effective at inducing ovulation as clomiphene is. This one is actually a pretty commonly used fertility agent. But you will not see raloxifene or lots have been used, just because it's not as effective. It will induce ovulation. It's an estrogen antagonist, and agonist effects increase gonadotropin release, so that's how it induces it. Some adverse effects of this one: hot flashes, night sweats, dizziness, mood swings, abdominal pain or bloating. They can have temporary visual changes. And then ovarian hyperstimulation, which we're gonna talk about a little bit more. Does anyone want to take a stab at what happens with this? Multiple. Yeah, multiple stations, right? It is effective in WHO class 2, often ineffective in WHO class 1 and 3. So when we're thinking about what patients to use this in, it's for caution, for non-invasive ovarian tumors, there's an increased incidence. All right, then our lesson law. With my adverse effects. It's a aromatase inhibitor. It induces ovulation and blocks conversion of testosterone and I can't say that, androstenedione to estradiol and estrone, which decreases negative estrogenic feedback to the pituitary and ultimately increases FSH, so resulting in an FSH surge and losing of that. So for some adverse effects, because mine can disappear, I will tell you, usually we see back pain with these patients, a lot of bone pain and hot flashes as well. Joint pain and muscle pain, those are pretty common.
Can you say those one more time?
Sorry.
You're okay, I'm just writing them as you say them.
So back pain, bone pain, muscle pain, hot flashes, and joint pain and muscle pain.
Thank you.
It is effective in WHO class 2. And it has reduced risk of multiple infections, which can be nice. It has a decreased anti-estrogen effect on endometrial and cervical mucus. And it also has this novelty use of IVF in breast cancer with the gonadotropin. So you can use this in breast cancer patients who want to go undergo IVF. It's a novel use. And something to note is it's not FDA approved for infertility. That's not FDA. And mainly the use of this one is for those that have poor outcomes on clomiphene. So we'll see what results. Our next class is dopamine agonists. The two common ones are bromocriptine and cabergoline. I'm sorry. They induce ovulation by decreasing prolactin. So obviously, our other category has hyperprolactinemia, and ovulation to decrease prolactin. It's used in hyperprolactinemic and ovulation, as I said. Bromocriptine, the difference between these two and when they're used, this one has less risk of birth defects. So for moms who are scared of the birth defect possibility with cabergoline, this one can be used. For this one, it has less side effects, notably nausea. The side effects here are missing, so I will verbally tell them to you. So blurred vision or double vision, headache. Some people have trouble sleeping, sneezing, or feel things that are actually not there. You know, it's really scary, but it's a magnet, so it's kind of. They also have pain and discomfort in their jaw and legs. And once again, the big one with this one, nausea, which a lot of people do not like nausea for obvious reasons. So that can be a reason to get this one versus. Does anyone need to say this back again? Yeah. Okay. All right. Blurred or double vision, headache, trouble speaking. Seeing, feeling, or hearing things that were not there. Pain in the arms, jaw, and back of the neck. Those are pretty cool. And if you look it up, there's a whole other laundry list of side effects. Okay. And then one that you may not expect to see, or maybe you did, I don't know, is metformin. Our good old diabetes up here. It's a biguanide, and the reason why it works, specifically for patients that have PCOS, is because it corrects hyperinsulinemia. This increases menstrual frequency and improves spontaneous ovulation. So for these patients, metformin can be really helpful. And it's one of the reasons why we probably reach for this first. PCOS thing. Abdominal cramping, obviously the major side effect there, and diarrhea. What you can tell people is that usually after a few weeks it goes away, for some people it does not, and it's very disturbing. Extended release formulations can help with that issue. And then B12 deficiency is another thing we do. Any questions about our oral agents? Yep. So, so basically, clomiphene, I know it says here, often is effective in class 1, but this is actually usually the first go-to PO drug, even though it's generally ineffective. But we're gonna talk about some more therapies that are generally uneffective. But these are our PO agents, so obviously before we reach for something that's injectable, we usually will reach. All right. Then we have gonadotropin therapy. And I put it here, ovarian hyperstimulation, because that's really what it's doing. It's indicated in PCOS without ovulation, no success with weight loss, clomiphene or letrozole. So for those patients that was not successful for, or from class 1, that those PO meds did not work. And then hypogonadotropin in ovulation with hypopituitarism. This can also be a first option. So we have HMG and FSH is our two main formulations. Bolistim, Gonella, Repronex, Nenifer, these are kind of the brand names that you'll see. Some adverse effects of these: fatigue, injection site reactions, ovarian hyperstimulation, and multiple gestation. For this one, I do want to point out that there is ovarian hyperstimulation syndrome that can often come with these, especially if we add on HCG here. What that is a life-threatening complication of ovulation induction. The ovaries will become enlarged. There can be cysts, there can be some third spacing happening, renal failure, and shock, thromboembolism, acute respiratory distress syndrome, and even death. So that's very serious and something we want to keep an eye out for with these. And then subcutaneous sleep boosters. So these are for the next one. Okay. And then HCG is Novarel or Reginald. So it's an ovulatory trigger.
Thank you.
And it's used in combo, not by itself, with clomiphene, HMG, FSH, and IVF cycle to time insemination or egg retrieval. And the reason why I say this is because it will actually be given as with one dose when we want the follicle to drop. So it's actually given 2 times this egg retrieval for IVF. Or if we're just inseminating and not doing IVF, you can time when that egg drops. We have come to the end. Any questions?
Oh, perfect time. Well done.